suspicion of pulmonary embolism. So as you see, previous pulmonary embolism of venous deep vein thrombosis, tachycardia, surgery or fracture in the past month, hemoptysis, active cancer, unilateral lower limb pain or edema, and also age more than 65. These are the revised Geneva clinical prediction rules. So you put 1 point, the original version is more complicated, but just use a simplified one. And if you use it and you have a score which is not more than 2, then the PE is unlikely. But if you have a score of 3 or more, then it's likely that the patient has a pulmonary embolism, and you should check and diagnose more, having in mind this diagnosis. These are some data on classification of venous disease, but I think you had spoken about it earlier. Now, what we should remember is we have a couple of diagnostic tools, and the guidelines are telling us something about the D-dimer measurements. Now, D-dimers are present also in other conditions, but if we have a low probability of pulmonary embolism and D-dimers, high sensitive assays, are negative, then we should exclude a pulmonary embolism. The new guidelines suggest us to use, instead of the D-dimer cutoff, and test adjusted with values of cutoff adjusted to age. The D-dimers are useful when you are in the emergency area and you have a patient with low probability of pulmonary embolism in order to exclude it. But you should not lose time and money and make D-dimer measurements to patients with a high probability, because they will be high. It's no use to go with this method. Instead of it, you should use the CT angiography. Now, CT angiography is probably the most useful tool for diagnosis in this situation. If you have a normal CT in people with low and intermediate clinical probability, you can exclude it, and then you should work for clarifying which are alternative causes for the symptoms of your patient. Now, if the CT is showing segmental or more proximal filling defects in a patient, then the diagnosis is sure. There are also other conditions. We shall not stress on the 2A and 2B considerations. From this point of view, I just want to synthesize which are the strengths of the CT angiography. It is quite available around the clock in most centers, which can be, this is probably true in rich countries, but not in poor countries. It is very accurate. It may provide alternative diagnosis. You do not lose a lot of time. But yes, of course, means some radiation exposure, some iodine contrast exposures with allergies and so on and so forth, contraindications for some conditions as severe renal failure or pregnant women. But yes, generally it's the first approach for a good diagnosis. As you see here in these images, yes, is a pulmonary trunk, the two pulmonary arteries. This is the thrombotic materials. You can see it. Yes, so it's a proximal thrombosis. Very large vessels are occluded, so probably the condition of such a patient is severe. Same images here, yes, thrombotic lesions, and you can also see the heart. Normally, the left heart, this one, is bigger, it's greater, it's larger than the right one. Here, the right ventricle is in fact larger than the left one, showing that there is a important right heart overload, so it is a critical condition for this patient. What else can we use for diagnosis? We can use the ventilation perfusion scintigraphy, which was 10 or 15 years ago the main diagnostic tool. But yes, it has less contraindications, it's not so expensive, it's strong validation, but it's very, very difficult as availability. For example, in Romania, we do not have any possibility to make a ventilation scan. We can do perfusion scans, but ventilation, due to some technical reasons, are not available. And also the results can be sometimes tricky with inconclusive results in almost 50% of the cases. Ventilation perfusion SPECT, of course, it's better. It has higher sensibility and specificity, but availability is even less. While pulmonary angiography was a historical gold standard for diagnosis, you could see injecting iodine the obstructed vessels, but nowadays it's very rare that we use it for diagnosis. So, due to what I told you before it, yes, when scintigraphy is recommended to reject the diagnosis without further testing, is a perfusion scan is normal, then you can say, yes, this is not a thromboembolic event. These are some images, as you see here. This is a case with pulmonary hypertension due to other conditions, with some little perfusion ventilation defects, while here you have a whole lobar area which is lacking, yes. So it's a huge thromboembolic event. Again, a comparison of the methods I spoke you about. Radiation exposure is a bit lower for scintigraphy and for SPECT. Highest radiation is in pulmonary angiography, so invasive testing. Now, of course, if we do not like to expose our patients to radiation, and whenever we can, we use non-irradiating and not invasive measurements. And for this, diagnosis, uh, echographic measurements are very useful. As I told you, normally the left ventricle is twice the diameter of the right ventricle. If we have a brisk, acute overload of the right ventricle, then we'll have an increased right ventricle here. As you see, four-chamber view, right ventricle, left ventricle. The right ventricle is in fact twice the diameter of the left ventricle, so it's very dilated. Normally, the interventricular septum is coming towards the left ventricle, helping him because he has a greater overload, pressure overload. Here, because of the right ventricle overload, the septum, interventricular septum, is flattened, yes. So we have the D letter sign of the left ventricle. And finally, because the right atrium is enlarged and because due to tricuspid regurg, the pressure in the right ventricle is high, in the right atrium is high, we shall have a dilatation of the inferior vena cava with a diminished inspiratory collapse of this area. So we have a lot of useful signs in echography, and as a difference of the aforementioned methods, we generally have a possibility of getting an echo in every emergency area in this country. We can even measure the pressure, evaluate the pressure in the pulmonary bed. Normally, the systolic pressure is around 30 millimeters mercury, and the mean pressure is below 25 or 20. So if we have a acute overload, we can find high pulmonary pressure, and we can measure it by measuring the velocity of the tricuspid regurg, by measuring the acceleration time of the pulmonary flow, and we can also measure some parameters which allow us to say there is a right ventricular dysfunction, increasing this decreased tricuspid annular plane systolic excursion, TAPSE. Yes, if TAPSE is low, below 16, this is a sign of important right ventricular dysfunction. What other non-invasive measurements could be done? In 90% of the cases, the clot which is obstructing the pulmonary vessels is coming from a deep vein thrombosis of the inferior limbs. So a lower limb compression ultrasonography can be useful because if it shows a proximal deep vein thrombosis in a patient with clinical suspicion, then the diagnosis is sure, and you see it's a class 1 indication for such patients. Magnetic resonance imaging, which is very important for other pathologies, cardiovascular pathologies, is actually not useful in the acute pulmonary embolism. It can be used in clinical chronic conditions, but here it has no place because it is not superior to CT. It means more time, it's less available, and so it's not really useful. So the diagnostic algorithm for a suspected high-risk pulmonary embolism will be making immediately a echography which is cheap and available. Yes, a bedside transthoracic echography. If we see the signs of high pulmonary pressure and right ventricular dysfunction, then yes, this is important. If the right ventricle has a normal function and the pressures are normal, then we should try for other sources if the patient is unstable, as I told you at the beginning, searching for other causes of shock and instability. But if the right ventricular is dysfunctional, then we should immediately check for a CT. If the CT is positive, then we shall treat the patients for pulmonary embolism. If the CT is negative, it can give us a clue for other etiologies for the shock. A shock can be hypovolemic, can be septic, and so on and so forth. These are some images of echo images. Yes, as you see, right increased right ventricle and right atrium. The left ventricle is some kind of appendage of the right one. Yes, this is a tricuspid regurg flow, which has a high velocity, more than 4 millimeters, meaning that the pressure is around 80. And you see here in color Doppler the flow of tricuspid regurg. And you also see here some images with can suggest where the clot is coming from. Here, for example, you have a partial obstruction of the inferior vena cava due to abdominal pathology and secondary thrombosis of the vena cava. It was actually a ovarian cancer. Okay, it's what we just discussed. And this is a synthesis of what we should do when we have the other situation. So we spoke till now about what to do with a patient with hemodynamic instability, meaning resuscitation, shock, or persistent hypotension and low perfusion of tissues. So in this condition, we shall as quickly as possible go to echo in the emergency room and as quickly as possible to CT. Now, if we have the condition of a more stable patient without hypertension, without shock, and so on, so is hemodynamically stable, then, as I told you at the beginning, if the probability to the Geneva score is low or intermediate, we shall do a D-dimer test. If the D-dimer is negative, he needs no treatment. We shall check for other conditions giving him symptoms. If the D-dimer test is positive, then of course we shall do the CT, because I told you CT is almost compulsory in this condition. And of course, the CT is the first one without dimer testing in a patient which is stable but has a high clinical probability with a score which is, yes, more than 3 Geneva score. There are some cases, presentation cases, but I don't think we have the time to do it. Now, what I wanted before talking on treatment of this patient is that diagnosis takes us a couple of minutes or of hours in order to make an echo, to make a CT, and so on and so forth. But if the condition of the patient is severe, if the probability is high or intermediate for pulmonary embolism, we should initiate anticoagulation as early as possible. So the patient is in a quite low condition, probability is high. We begin with intravenous heparin, and then we shall continue or cross to another treatment while we have the data from the CT and other evaluation. Okay, this is a strategy. Patients with acute anticoagulate if the patient is unstable with high risk or intermediate risk and clinical signs of severity or morbidities, then he should be treated more aggressively. While not having signs of severity, not having right ventricular dysfunction, then he is a low risk patient and we can be not so aggressive and we might even discharge him quite early. Now, the severity index we are speaking about in the slide before are coming from this PESI scheme you can see here. PESI comes from pulmonary embolism severity index, and the severity index is linked to age. So old, more than 80 years is an additional risk factor. So is cancer, chronic heart failure, or pulmonary disease. Tachycardia, low blood pressure, and also desaturation of a patient. Speaking about desaturation, I would like to remind you that one of the causes of mortality in the COVID pandemic is a high risk of thromboembolic events. So a lot of patients having COVID are developing thromboembolic events. This is why most of the medium or severe cases have to be anticoagulated during the disease and a couple of weeks after. So coming back to the PESI area, as you see, there you can put a point for every predisposing condition. And there is a high difference on the prognosis of these patients. If none of the risk factors mentioned is present, then the mortality is very low, below 1%. While if you have at least one of those patients, of those characteristics, the mortality is more than 10%. So it's a very high mortality. 10% mortality means more than the mortality of acute myocardial infarction treated nowadays. So it's very important to calculate this PESI score for a patient because the high-risk patients, a lot of high-risk patients will die if we do not treat them very early and very aggressively, while the low-risk patient will go with a very good future. So high risk of early mortality are for those which are unstable, which have a PESI score, high PESI score, which have right ventricular dysfunction, and also elevated cardiac troponin levels, which show the reaction and the dysfunction of the right ventricle. An high intermediate means having all these three factors here, but not being hemodynamically unstable. Intermediately low early mortality for those having a high PESI score, but no right ventricular dysfunction, while low mortality is characteristic with the lack of all these points. So the initial risk stratifications using the PESI score is very important because it gives us a clue how aggressively we should treat our patient. And how do we treat them? If we have a high risk patient with hemodynamic instability, we should, as quickly as possible, treat them, use thrombolytic therapy. Thrombolytic therapy has a chance of dissolving the clots and, of course, liberating the pulmonary vessels that makes over load of the right ventricle improve and the prognostic of the patient improve. But why shouldn't we use this thrombolytic therapy for everybody if it's so good? Well, it's good, but we have to take into account also the risk for hemorrhagic complications during this treatment. And there are a lot of such, the risk for hemorrhagic complication is quite high. And if initially 30, 40 years ago, when thrombolytic therapy became available, people tried to use it in other conditions with lower risk, it proved a bad idea because the patient bleeded and sometimes were even major bleedings. So it's not a good idea. We should use thrombolytic therapy just in patients with hemodynamic instability or those with high intermediate, which are worsening in spite of other therapy. So what the guidelines are telling us, as I told you, to begin anticoagulation as soon as possible, uh, even before having the complete diagnosis, if the patient is at risk, intermediate and high probability of a thromboembolic event. So high risk will have thrombolytic therapy. And there are two conditions which are very rare. I have seen them just for a couple of times in 30 years. If you have a very, let's say, big clot, very proximal, for example, occluding the bifurcation of the main pulmonary artery, and you have a surgical team available, then yes, you could have a surgical pulmonary embolectomy. It's a class 1 indication nowadays, but you should understand this is an exception, not only in Romania, but also in other areas. So it's probably less than 1% of patients with severe pulmonary embolizations that are treated surgically. It's here a overview of the dosage and contraindication of fibrinolysis of thrombolytics, RT-PCR, streptokinase, and so on and so forth. It's not important for you to have in mind the dosage. You can find them in any instructions, but just look a bit on the contraindication, absolute contraindications, meaning recent strokes, central nervous system, neoplasma, um, recent less than 3 weeks major trauma surgery or head injury, bleeding, active bleeding. And of course, there are also some relative contraindication. Here you can balance between the benefit and the risk of giving this medication. When we have a acute right ventricular dysfunction with hypotension, persistent hypotension or shock, yes, we can use medication to improve the contractility. Norepinephrine, dobutamine, and so on can be used in, of course, in the intensive care area, and very rarely there is no effect of the classic medications. You can use the extracorporeal life support with an ECMO veno-arterial, so you are bypassing the lungs for a while, getting the external oxygenation of the blood, and allowing the patient to survive. Of course, you cannot use it, but for a limited time. Beside thrombolytics and surgery, a class 2A indication is given to attempts to disocclude the pulmonary arteries, introducing a catheter into the clot and trying to get part of it in less important arteries and opening the main artery, which makes the patient hemodynamically unstable. So this condition can also be used. It has been used also in our institution a couple of times. You see that the indications for norepinephrine, ECMO, and so on are 2A or even 2B. So not everybody is sure that using them brings a real benefit. Now, if the patient is not hemodynamically unstable or in a high risk and worsening condition, then we should treat the patients with classic anticoagulation. Anticoagulations generally use low molecular weight heparins or fondaparinux. But also there is now experience with new anticoagulants, apixaban, dabigatran. Edoxaban is not available in Romania, but it's elsewhere, and rivaroxaban. So both can be used in these conditions. You see here the dosage, and you can find them also in the guidelines. About the oral anticoagulations, if you have treated the patient for a couple of days with heparins, then you have to overlap if you want to go to classic anticoagulations in order to have an INR of 25 when you stop the heparin and continue just with oral anticoagulants, antivitamin K. While the novel anticoagulants should not be used in severe renal impairment during pregnancy and in patients where the thromboembolic event was favored or caused by a antiphospholipid antibody syndrome. In these situations, you should use the classic anticoagulants and not the ones. This is a synthesis in the guidelines of the recommendations. A couple of words about a indication which was a bit larger a couple of years ago. As I told you, most of the clots are coming to the lung from the lower limbs. So if somebody is at risk of repeating a thromboembolic event because there are more clots in the lower limbs, and anticoagulation is not efficient, then you could stop the clots on their road, inserting a filter, a special filter, in the inferior vena cava. Now, the results were not good in most of the cases, so in this moment, the indication is just a 2A class indication, and it should be considered just in those patients which have an absolute contraindication for anticoagulation because of high bleeding risk, or in those who have a recurrence of the pulmonary embolism despite therapeutic anticoagulation. So yes, we have the possibility to do it, but it's quite seldom that a patient really needs a inferior vena cava filter. Now, what about the discharge of these patients? Of course, if you have a PESI high-risk patient, you should not discharge him. But due to the fact there are a lot of thromboembolic events, of course, people wanted to know if some of these patients could be early discharged on anticoagulant treatment at home, which would be cheaper and better for them. And these are the criteria, the so-called Hestia criteria. So the presence of any of these criteria, hemodynamic instability, necessity for embolectomy, high risk of bleeding, desaturation, severe pain, medical or social reasons, low clearance of creatinine, so problems with kidneys or severe liver problems, or pregnancy. In all these conditions, you should not discharge early the patient. You should maintain him in hospital because he is still at risk. Now, you treat a patient, he survives, but you want to know something about the risk of recurrence, because as it's a deadly disease, and you should know if he is at risk, and you should know if you can do something else. One thing you could do is that if the risk is high, then you would continue the anticoagulation for years or long life. And as you see, there is a high risk category, including the active cancer, previous episode of venous thrombosis, which were not due to a major transient or reversible factor as a surgery or something like that. The antiphospholipidic syndrome is also a high-risk condition, while other conditions have a medium risk for repeat. The risk is quite low um, in the condition you see here. So probably here you should discharge earlier and you should discontinue the treatment earlier. This is a time for anticoagulation, which is recommended by the guidelines, and you see, yes, at least 3 months, but longer anticoagulation is recommended in various conditions. Um, we shall not cover all this data because it's a bit more complicated and it is quite quite late. There are some tables in the guidelines which show special conditions and what we should do about diagnosis, avoiding radiation or avoiding those medication which are contraindication in pregnancy, for example. And it's just one thing that I should tell you is that very few, around 1 to 3% of patients who have had a pulmonary embolism will develop in the future a condition which is called chronic pulmonary post-embolic pulmonary hypertension. It is a severe condition which high mortality if not operated. So this condition develops quite rarely, but it should be recognized. And the most important sign is that more than 3 months after the acute event, the patient has dyspnea. So any patients with a dyspnea persistent more than 3 months should be seen by echo, and if there is a suspicion of chronic pulmonary hypertension, then a catheterization is done, and the patient is a candidate for surgery, so-called endarterectomy, pulmonary endarterectomy, which is a high-risk surgery, but which, when successful, will bring the patient back to a normal life. That's all. If you have questions.
No, I don't think there are any questions.
I don't know. I'm not sure. You'll be able to see thromboembolic patients, acute thromboembolic patient during your stay in the hospital because the special conditions we have now. You have all the data I showed you, and actually most of the slides are coming from the European guidelines. If you are on the sixth or on the fifth or seventh floor, you will probably be able to see some echo exams with right ventricular dysfunction and overload, mostly not to acute conditions, but due to chronic pulmonary hypertension. The CT remains, as I told you, the main tool for diagnosis. Unfortunately, in spite of the fact there is a CT in the same complex, yes, in the other building, We have unfortunately a problem because due to risk of allergic conditions and so on, the CT with iodine contrast are not done later than the evening. So unfortunately, if somebody comes with high suspicion of pulmonary embolism during the night, we shall treat him not according to the guidelines. We should probably begin with thrombolysis or anticoagulation on the clinical suspicion, and we shall have the CT confirmation just later the next day. So real life is not like in the guidelines, and it's probably also in the countries where you are coming from that not always you can follow the guidelines. You have to adapt to local conditions. Having the basic information about pulmonary embolism is important for you because just 3 or 5% of you will be cardiologists. But these patients, in fact, in the acute phase, can be met wherever, in the street, in the cabinet of a family doctor, in surgery, in orthopedic, in gynecologic. So whatever will be the specialty, you should know and remember that a patient with chest pain or dyspnea or hemodynamic instability might be a thrombotic pulmonary embolism, and he should be as quickly as possible sent for confirming diagnosis and for aggressive treatment. Yes, so this is the message. Knowing the risk factors, knowing the Geneva scoring, knowing the PASI scoring about the high or low severity patients. Okay, that's all. Have a good
Thank
day.
you. Have a
And
nice day.
tomorrow, same time, Professor Popescu.
Yes. Thank you so much. Have a nice day.
Bye bye.
Goodbye.